Good morning, I'm Dr. Chen Wei-Yu, Division of Colorectal Surgery, and I'm in the Changhua Christian Hospital. Today we are going to introducing you the topic of advanced laparoscopic colorectal surgery. In the current age of minimally invasive surgery, laparoscopic technique has accomplished a major progress in the treatment of colorectal cancer. General history of laparoscopic has previously been described. In Germany, Kurt Smith performed the first laparoscopic appendectomy in 1982. Jacobs, and in 1919, he performed the first laparoscopic assisted colectomy. Compared with cholecystectomy, appendectomy, or nasal fundoplication, laparoscopic colon surgery was a significant, more challenging operation as it involved often more than one abdominal quadrant, required determination of the correct target segment to be removed, safe identification and transection of named vascular structures, mobilizing and resection of the ball, specimen retrieval, and creation of an anastomosis. So how is laparoscopic colectomy done? Today, because of the major breakthrough in laparoscopic surgery, it's the result of technological progress with invention of the computer chip television camera that allowed all members of the operation team to watch and to actively participate in a procedure. Numerous publications from around the world mirror the sudden interest of surgeons in the new video laparoscopic technique, exploring applications in almost every organ system. Close collaborations between industry and surgeons were at the forefront of developing dedicated instrumentation and technology according to the true needs in the operation field. Multiple aspects of various surgical procedure steps were optimized by introduction of new devices and equipment, such as edge and sealing devices, staplers, and clip appliers. Right now, laparoscopic surgery can be applied in all our colorectal surgical field. Laparoscopic colorectal surgery involves the use of several small incisions through which a specialized camera and several laparoscopic instruments are inserted. An insufflator blows carbon dioxide into the peritoneal cavity, creating a pneumoperitoneum that provides a working space to perform the operation. Seating of the operation room table in various positions. During an operation, use gravity to allow intra-abdominal organs to fall away from the area of dissection, providing necessary exposure that would normally be achieved through the use of retractors. Intestinal retraction requires laparoscopic ligation of large vessels, mobilized in the use of energy devices such as bipolar vessel sealing device or ultrasonic coagulation devices, and remove all the long floppy segment of colon, and restoration of intestinal continuity with endo-GIA or other staplers. Once the colon segment has been completely mobilized and its blood supply has been divided, a small skin incision is made to exteriorize the colon. Resection and anastomosis are performed extracorporeally, and the rejoined colon is placed back into the abdomen with GIA or EA staplers. So what are the principles of colorectal surgery? Principles of colorectal surgery are the same with open surgery. Here are the key principles. In laparoscopic surgeries, we always use medial to lateral approach for what we will mention below. First, we have to identification of the ureter. Second, careful protect the anatomic nerves surrounding the colon. Third, ligate the supplying vessels without injure the surrounding organ or vessels. The intra-abdominal mobilization and resection the whole mesocolon and the tumor for adequate safe margin and lymphaectomy. Finally, we will make anastomosis of the residual intestine. You have to remember laparoscopy is equal to open surgery, and medial to lateral approach is equal to lateral to medial approach. So here we take right hemi colectomy for example. The right colon lies on the patient's right side, suspended laterally by peritoneal attachments to the right side of the abdominal wall. Superiorly by attachments to the undersurface of the liver and posterior diaphragm. Medially, it is mesentery. Either colic artery and vein and the right colic vessels, if they are present, run through this sleeve of mesentery. The colon is adherent to the retroperitoneum on the right side of the abdomen and covers the right gonadal vessels in the right ureter. The inferior vena cava is the next most medial structure on the right side. The hepatic fracture, the fault at the junction between the right colon and the transverse colon is adherent to the anterior surface of the kidney by vascular attachments to Gerota's fascia. The first and second portion of the duodenum adherent to the undersurface of the mesentery of the right colon and proximal transverse colon. The gallbladder is sometimes adherent to the cephalic surface of the transverse colon at the hepatic fracture. The space behind the right colon is triangular shaped, with the flat horizontal surface at the hepatic fracture running from the abdominal side wall toward the midline along the line of the great curve of the stomach. Vertical axis follows the right lateral side wall of the abdomen. The hypotenuse runs from the fusion plane of the secant and the pelvic ring over the top of the right iliac artery and vein at about the point, where the ureter passes over the iliac vessels toward the midline, over the aorta up to the base of the pancreas along the third portion of the duodenum. The triangular retroperitoneal area is potential space with a vascular attachment and allows the right colon to be lifted completely from the retroperitoneum during dissection. It's very important for the first step. Release of all suspensory attachments allow the right colon to be made into a midline structure. Either colic artery and vein arise from the superior mesenteric artery and superior mesenteric vein in the mid portion of the SMA below the duodenum. Right colic artery is a variable structure and may be present as a separate structure or as part of the ileocolic trunk. The right branch of the middle colic artery exists through the pancreas tissue from its origin on the SMA as a portion of the middle colic trunk at the base of the transverse mesocolon, which we will all see in the picture. So when it comes to patient position, the patient is positioned in the modified lysotomy position with the legs in Allen straight ups with sequential compression boots in place. A beanbag attached directly to the operation table with Velcro is rolled around the patient and deflated to fix the patient in position. The beanbag keeps the arms at the patient's side and allows the table to be placed in stepped Chen-Lemberger and airplane to the left during the operation. Trocar side, which we can see in the picture, is typically at umbilicus and the suprapubic in the left flank position. The camera operators and the operators the camera through the umbilical port. The operating surgeon stands at the patient's left hip or between the legs as needed, and the operators instrument through the left flank and the suprapubic ports. The 15 mm mercury pneumoperitoneum is maintained with a pressure-controlled insulators. Camera cord, light cord, and carbon dioxide cord in the path of the table from the patient's left ureter to the instrumentation tower. The monitor is placed outside the operation surgeon and camera operator. Two monitors are available. One is at the right shoulder and one is in the right hip. And here we can see the operation is begun by abdominal exploration by using the laparoscope and instrument to move an abdominal contents before placing the table in steep Trendelenburger and airplane left. The lever should be evaluated after the table is positioned. Momentum should be placed over the stomach to the left upper quadrant. The small ball should be retracted from the pelvic to lie in the left upper quadrant. The 5 mm weight grasper is a good instrument to flip the small ball up into the left upper quadrant with a reverse C motion. The principle should be to avoid grasping any individual piece of ball on the ball itself. Using mesenteric fat or epiploic fat to move portions of the intestine is appropriate. The second is lifted to the anterior abdominal wall using the 5 mm grasper through the suprapubic port in the operator's left hand. An energy source such as bipolar, monopolar cautery, or harmonic scalpel can be used to incise along the base of the peritoneum from the pelvic brim over the iliac vessels toward the duodenum and the midline of the abdominal cavity. This incision allows a plane to be developed in the retroperitoneum over the structures that are found posteriorly. After the visceral peritoneal incision, the right ureter is identified across the iliac vessels close to the bifurcation of the aorta. The gonadal vessels are further lateral and run parallel to the iliac vessels. The psoas muscle lies posteriorly and should be a boundary of dissection. A vascular plane that is encountered is used as the dissection plane and can be bluntly dissected in a posterior sweeping direction. Allow the mesentery and secant to separate anteriorly from the posterior structure. And the secant should be completely mobilized from the retroperitoneum all the way out to the side wall of the abdomen using the left hand graspers for traction upward, and the right hand instrument to develop the plane. Then the dissection is carried in this posterior plane up to and around and on top of the surface of the duodenum. The duodenum should be separated from the overlying mesentery of the right colon using the left hand for anterior retraction. The dissection is continued up to the hepatic fracture, peritoneal attachment, and exposing the entire sweep of the duodenum. A portion of the head of the pancreas, the lateral aspect of the middle colic vessels, is the red arrow which was showed in our slide. The anterior portion of the kidney is exposed with the same maneuver, with upward retraction and downward countertraction. Traction and countertraction is very important. The mesentery and right colon are laid toward the anterior abdominal wall while pulling the vascular tissue, posteriorly using the instrument in the operator's right hand. Most of the retraction is accomplished with the left hand on the grasper through the suprapubic port. Then the patient is placed in reverse transfer position and the attachment of the hepatic fracture to the retroperitoneum are lifted anteriorly and divided with an energy source along the line between the liver and the transverse colon. This maneuver allows entering the peripheral dissect plane of the right colon posteriorly and is seen as a purple hue in the posterior peritoneum. And the separation of the obenton attached to the transverse colon so that the laser sock can be entered and the transverse colon released from the laser sock, head of the pancreas, and the undersurface of the entrance of the stomach all the way out to the right side wall of the abdomen. The hepatic fracture is completely mobilized from the undersurface of the liver and the posterior dissection is connected to the right upper quadrant dissection. The patient is turned to Trendelenburger position, and the thickening is grasped at the iliac valve and lifted anteriorly to the abdominal wall. This maneuver provides the tension need to allow the ileocolic vessels to be easily seen in the center of the right column. So once again, tension and contraction is very important. The final laparoscopic maneuver of the right column dissection is the release of the lateral attachment of the column from the right side wall of the abdomen. The second is grabbed and lifted anteriorly with the left hand on the grasper through the suprapubic side. Energy source through the left lower quadrant can divide the lateral attachment. Alternatively, the left hand could also run the energy source through the suprapubic trocar. And the right side hand on the grasper through the left flank side could retract the second toward the midline to facilitate the division of the lateral attachment. These maneuvers allow the right column to become a midline structure from the midline of the transverse column all the way to the terminal ileum. Then the umbilical trocar side is enlarged to about 5 centimeters. The wound protector is placed through the incision to allow the specimen to be delivered through the 5 centimeter incision in the umbilicus. The specimen is delivered through the anterior abdominal wall in its anatomic position. Transverse column is transected with a 75 mm liner culture stapler at the level of the abdominal wall. The terminal ileum is delivered through the abdominal wall adjacent to the transverse column and transected at the point appropriate to the disease process. Usually would take 10 centimeters proximal to the ileocecal valve with a 75 mm liner culture stapler. Then the two cut ends of the ball, which include the transverse column and the terminal ileum, are lifted through the abdominal opening, lined for stable anastomosis. The functional end-to-end or side-to-side anastomosis is accomplished by placing two sides of the liner culture stapler through the antimesenteric corners of the transverse step line to attach the terminal ileum to the transverse column. The transverse opening is then closed with Alice clamps, and the 75 mm liner culture stapler is placed across the transverse opening with the stable lines of the liner culture. Stapler distract as far as possible to create a triangular anastomosis. The transverse stable line is oversewn with an inverting Lambert absorbable suture to invert the transverse stable line. The mesenteric defect between the transverse column and the terminal ileum can be closed with a running 3/0 absorbable suture to help ensure that there are no twists in the ball and prevent herniation through the opening in the mesenteric defect. A 3/0 absorbable suture is usually also placed at the apex of the ileocolic GIA anastomosis to protect the crotch of the GIA cerebral line. The wound protector then is removed, and the abdominal incision is closed with a running 1/0 looped absorbable suture. The skin can be closed with skin staples or subtular suture, or to result in a 5 centimeter incision. The amount of ball resected and the position of the ball on the abdominal wall can facilitate and maintain the ball without twists, and verifying that the appropriate specimen has been removed. So there are several advantages of laparoscopic surgery, such as death blood loss, faster recovery, early return to gum function, low morbidity, magnified field allows precise dissection, and reduced pain, improved cosmesis, decreased adhesion, decreased wound infection rate. But there are also some disadvantages of laparoscopic surgery, such as steep learning curve or some costs, like instrument or equipment. There are also some of the disadvantages, such as practical and technical limitation. like clothing of instruments in the pelvic. Broom can obscure vision. Retraction of the rectum can be very difficult due to the anatomy. Division of the rectum can be difficult. Identification of tumor site can be difficult. Longer operation times and pneumoperitoneum may cause gas emboli or decreased venous return. All these problems now can be solved or be overcome in today. Because of the progress of laparoscopic surgery experience in our hospital and the improvement of newly technology around the world. How, when it comes to the learning curve, the steep learning curve was acknowledged through the literature. At least 20 to 15 laparoscopic cases were considered the minimum to achieve basic proficiency in the technique. Along those lines, the professional societies like ASCRS, ACS, SAGES support the use of laparoscopic for cancer by appropriate trained surgeons and engage in respect training protocols. So when it comes to the outcome, in the United States, a well-designed prospective randomized multi-center trial was conducted under the umbrella of the Nation Cancer Institute to document non-inferiority of the laparoscopy approach when compared with open surgery. Other trials were initiated in other parts of the world, most notably in Spain, United Kingdom, Hong Kong. While with large picture remain in evolution, all studies, including several meta-analyses, came to a similar conclusion that laparoscopic colectomy in skilled hands was associated with shorter post-operative recovery at the price of longer operation times. But most notably, it was safe and oncologically at least equal to the standard of open surgery. So here comes to our conclusion. Laparoscopic surgery has been a major revolution in surgery and the clear has become a core technique in colorectal surgery. Fine-tuning of its applications remain in evolution. At times of economic constraints, institutions should resist to jump on every single trend, but employ the wisdom of controlled research to define the true progress that results in measurable value for the patient. Finally, I suggest that beginners can start with laparoscopic appendectomy to familiar with the laparoscopic technique and devices, which we have mentioned previously. Also to allow your members to familiar with the procedure, and then you can try the laparoscopic colectomy gradually. Thank you.